Hi, this is Dr. Nick, and this is the last section in the basic course on ECG interpretation. I'm going to talk about ventricular tachyarrhythmias. And this is a complicated subject, but we're going to try to make it clear for all of you out there. So this first lesson is really about the terminology and about classifying ventricular arrhythmias and trying to make some sense out of it, because although the books may show you typical examples of ventricular tachycardia and ventricular fibrillation, there's still some misunderstanding out there, and a lot of people have some incorrect ideas about what it should look like and what these arrhythmias represent. So let's get started. First, when you talk about ventricular tachyarrhythmias, you're talking about arrhythmias arising from the ventricle, as opposed to supraventricular arrhythmias, which arise from every tissue above the ventricle, including the AV node and the AV nodal tissues in the atria itself. All right, so we're talking about rapid beats that arise from the bottom chamber. There are two ways to classify these. First is the mechanism of the tachycardia. Is it due to an electrical short circuit that's going round and round? Or is it due to a single automatic focus that's firing? And I'll talk more about this in the intermediate course when we cover mechanisms of arrhythmias. But for this level, just understand that there are two different mechanisms that give rise to rapid beats. One is sort of an electrical short circuit, and the other is just a discrete focus in the heart that starts firing rapidly. Now, the other means of classifying these ventricular arrhythmias is based on rate. The rate kind of gives you major classifications. And so if the rate is less than 100 beats per minute, we generally refer to it as accelerated idioventricular rhythm. Remember that an idioventricular rhythm is something that we can recognize during very slow heartbeats, such as during complete AV block, when the idioventricular rhythm serves as an escape rhythm. You've heard of idioventricular escape rhythms. Generally, they occur at rates of around 25 to 35 beats per minute or so. So if the Purkinje fibers out here are able to fire at, say, 35 beats per minute, so anything higher than that would be considered an accelerated idioventricular rhythm. So up to about 100 beats per minute, and some people say 120 beats per minute, and sometimes it depends on the way it behaves. Ventricular tachyarrhythmias in the range of 40 to 100 beats per minute are considered accelerated idioventricular rhythms. And the second chapter in this section is just about that. Now, ventricular tachycardia meaning fast heartbeat, of course, is considered any rates above 100, and some people say 120 beats per minute. But there is a category that some people have used, and that is ventricular flutter. Ventricular flutter is defined as rates between 250 and 350 beats per minute. Not everybody uses that terminology, but figure ventricular tachycardia is anything from 120 up to 250, and then above 250, you might refer to it as ventricular flutter. Ventricular fibrillation generally occurs at rates of greater than 350 beats per minute. And there are differences between these as well, having to do with how the QRS complex looks during these arrhythmias. In terms of the appearance and duration, most of the time we're dealing with ventricular tachycardia. So let's characterize ventricular tachycardia. You can have sustained ventricular tachycardia or non-sustained. Now, sustained usually implies that it just keeps on going and going and going and doesn't stop unless someone sort of interferes with it, let's say with an electrical shock across the chest called a cardioversion. But in fact, the definition of sustained is 30 seconds or more of ventricular tachycardia. Or if the patient is cardioverted out of ventricular tachycardia in less than 30 seconds because they have no blood pressure, let's just say. So if someone gets shocked out of VTAC, that's what we refer to it as VTAC. If someone gets shocked out of VTAC, then kind of you might as well just call it sustained, because who knows how long it would have lasted. But the true definition of sustained is greater than or equal to 30 seconds. Non-sustained, of course, means it stops by itself, and it may last anywhere from 3 beats all the way up to 30 seconds. Now, why do I say 3 beats? Well, let's go back to the ventricular ectopy. If you remember that if you have 2 beats in a row of ventricular ectopy, if you have 2 PVCs in a row, we call that a couplet. And if you have 3 beats in a row, some people actually call that a triplet. But to be accurate, 3 beats in a row or more is really considered non-sustained ventricular tachycardia. Finally, we characterize ventricular tachycardia as either monomorphic or polymorphic. Now, what does that mean? If you look in one lead and all the QRSs look the same, that they have a very consistent appearance to them, we call it monomorphic. On the other hand, polymorphic refers to the morphology or the appearance of the QRS complexes, and poly means many. So this arrhythmia may start as a monomorphic, but then it changes, and you'll have different QRS complex morphologies. Some of them may be going down, some of them may be going up, some of them may be very small. The idea is that it's changing, and we'll get to specific examples of this in the last chapter of this section. Now, the other thing I want to touch on in this chapter is that if you have a rapid heartbeat going on in the ventricle, and you have ventricular tachycardia, let's just say, what happens to the atria? That depends, for the most part, on how the AV node behaves. As I mentioned in some older lessons, the AV node in some patients is capable of conducting in a retrograde or backwards direction. But that depends on a lot of things. It depends on how the AV node is actually wired, and so each patient is an individual, and some people can't conduct no matter what. It also depends on the autonomic nervous system and how much adrenaline is in the patient's system, because retrograde or backward AV node conduction is enhanced by adrenaline. And under certain circumstances, you can get conduction in a backward direction on that basis, whereas if the patient is relaxed, they won't conduct backwards. Finally, the rate has a lot to do with it. At slower rates, if a patient were to have a slow ventricular tachycardia, you may, in fact, get one-to-one conduction up the AV node, and you'll actually see retrograde P waves following each QRS complex, kind of what we saw in the ventricular ectopy section of this course. But just like the AV node conducts worse at faster rates in an antegrade direction down the AV node to the ventricles, and you get things like Wenke back and second-degree AV block in an antegrade direction, the same thing happens to the AV node in a retrograde direction. And so if the ventricles are going faster than the AV node is capable of conducting, you can see retrograde AV block. Sometimes it's a typical Wenke back kind of phenomenon with the R to P intervals getting longer, and sometimes there'll be 2-to-1 block, and sometimes, in fact, you'll have complete block of conduction up to the atrium. And in that case, what happens is the sinus node simply fires as if nothing else is going on. And you have sinus P waves that you can actually map out with calipers marching through this ventricular tachyarrhythmia. Now, whenever the ventricle is going faster than the atria, and we can see P waves going through this arrhythmia that are slower than the ventricle, when the atrial rate is less than the ventricle, we refer to this condition as AV dissociation. Now, AV dissociation is a little bit different from AV block. True, when you have complete AV block, the atria and the ventricles are disconnected from each other, and they're at different rates. But in that case, the atrial rate is faster than the ventricular rate, and we call that complete heart block or complete AV block. But if the ventricular rate is greater than the atrial rate, you can still have a situation where the A and the V are doing different things, beating at different rates. But if the ventricular rhythm is faster, basically the ventricles are setting the pace of the heart, and then we call it AV dissociation. It's a subtle difference, but you need to be able to appreciate the distinction, because AV dissociation is really the hallmark of ventricular tachycardia. And I've seen people mislabel strips because they don't understand the difference between these two terms. Okay, well, I think that's enough theory and physiology. So if you go on to the next video in this section, we'll start talking about the first of these ventricular tachyarrhythmias, and that is AIVR. So for the ECG Academy, this is Dr. Nick. Thanks for watching.